So, a very good evening to all of those who are present here, and welcome to the Immunoallergy Conclave 2.0 and RACCON 2026, the online sessions. And this was supposed to be the first inaugural session because we wanted Dr. Vedanthan to be the first speaker in our conclave. But because of certain arrangements with certain speakers, we still, in our minds, feel that this is the first and the most important talk of this conclave. And since this is happening under the aegis of Rheumatology Association Gujarat, uh, we have planned a small, short inaugural ceremony for the online sessions. And to pass the baton on, I ask Dr. Reena Sharma. She is the president of Rheumatology Association of Gujarat currently, to give a few words of encouragement and speak a few words for the conclave.
Thanks, Kunal, and good evening to all of you. So before we start, actually, we had already 2 online sessions earlier, but I think this is the pioneer session and one of the most important topics to understand. And it gives me a great joy as being the president of Rheumatology Association of Gujarat to warmly welcome you all to this very special conclave, which is on allergy and immunology. Though we've been meeting, but this is an online session, but I think the screens can't do us apart. This is as good as being meeting in person with all of you. And we feel all connected today by the same spirit of curiosity and collaboration. And we all need to take care of our patients. That is also very important, and learn a new aspect apart from immunology, that is of the allergy. And these are two fields, mainly the allergy and immunology, which touch each one of us in our practice very often. And whether we are rheumatologists, physicians, or pulmonologists, we do have an overlapping patients with this kind of symptoms. And this conclave is our chance to learn from some of the finest experts to share their experiences and to build the bridges between the specialities. And I'm especially grateful to all the speakers, the faculties who have taken their time out from their busy schedules to take the lectures for us online and then being present in person when we actually do the conclave in February. And with this, I think it's a heartfelt thank you to Kunal also to have organized this, and he's been doing working very hard to organize this in a great way, and it's been going on smoothly till now, and I hope it continues to grow that way. And the in-person meeting in February, which is extended part of the RAG Con next year, will also be a great conference. And with this, I welcome you all once again, and let's get started.
Thank you. Thank you so much, ma'am. And the two senior most rheumatologists or immunologists in the state of Gujarat are our conference organizing chairs. So it's Dr. Namisha and Dr. Bankim. Dr. Bankim Desai was the chair or the conclave session chair for the last meeting. So I think you know him well. Uh, Dr. Namisha, if you can speak a few words, ma'am.
Yeah. Thank you, Kunal. And as the organizing chair, along with Dr. Bankim Desai, I welcome you all to the official inaugural session of this conclave, Immunoallergy Conclave 2.0. Right? This has been thought of, conceived, and is being actually smoothly progressing with the efforts of Kunal as organizing secretary and Pravin Isaria in Australia as the scientific chair. They have a very illustrious list of people to initiate us into the lesser known world of allergy and immunology. And we are really looking forward to it. It's, for me at least, it's a completely new field. I join Reena in welcoming you all to this meeting. The first half of this conclave has been conceived as an online meeting to initiate us into this very interesting subject. and there'll be about 15 to 17 online talks before we actually meet in early February for the conference in Ahmedabad. The first two talks, because of the change in the sessions, were by Dr. Philip and Dr. Pereira. We start off the first talk with of the inaugural session with Dr. P.K. Vedanthan's talk, and we will have the rest of the inaugural ceremony before I introduce Sir formally.
Thank you. Thank you so much, ma'am. So we have our scientific chair, Dr. Praveen Hisaria, also present. I'm not so sure. If I can ask all of you to mute your this thing, because I can see all of these muted. I'm not so sure who the additional voice is coming. Achha, okay. So Dr. Praveen is the probable reason why I came into allergy and I started liking allergy. He's been my sort of guru in all things allergy. And I think if you meet and see him practicing allergy, you'll all fall in love in allergy again. So thank you for agreeing to be a part of this conclave, sir, and a few words from you too.
Yeah, thanks, Kunal. I hope you all can hear me properly, actually. I'm speaking from my mobile. So, first of all, thanks actually for giving me this opportunity, Kunal. And I'm so glad that allergy has finally found a home in India. I think it was a bit of a neglected field, not because there were not many experts around, but I guess the burden of the disease was also less because the lifestyle diseases were not that much in vogue and we were more in keeping with illnesses which were organ threatening or life threatening. But I'm so glad that instead of it being, fragmented in its care by being looked after by the respiratory physicians, the dermatologists, the ENT doctors, as well as some physicians, as well as quite a few illustrious allergists as well. But it did need a home of its own. And I guess no better than immunologists in terms of what advances we've seen in last few years, where the basic immunology, initially it used to be just type 1 hypersensitivity and IgE. And now, as we know, the type 2 inflammation and proceeding from phenotypes to endotypes and now to even the genotypic phenotypic correlations has seen it come a long way. And I almost see, as I keep saying, when I get to see my junior colleagues, is that I think allergy currently is at a state where rheumatology was about 20 years ago in terms of the suite of agents that we are going to see in terms of our therapeutic armamentarium. And with the final dissection of the immunological pathways and the biologics becoming so readily available, as well as the change in the lifestyle that we are seeing with the urbanization of the Indian rural people and the increase in the amount of allergies. So look, it gives me great pleasure. I should be honest in admitting that I shouldn't be taking any share of the fantastic program that has been created. I think it is largely due to Kunal's hard work in terms of communicating with them. If at all, I was just CC'd onto their emails and didn't do much more than that, except say thank you to people who are accepting it. So I think it is a mammoth task that Kunal has undertaken, almost to the levels of a certification course, if I may add, and which will conclude with all of us meeting in Ahmedabad. And we very much look forward to that. So I guess it's fitting to say, Dr. Vedanthan, I'm so glad to see you. See you now, and I'll see you next week when we give a talk together at the pediatric conference, and look forward to interacting with you a lot more. And I have heard so much about with you, sir. So welcome to this forum. And I guess officially it's already been open for 2 weeks, but now it gets officially inaugurated under the RAG brand. Thank you.
Thank you.
Yeah. So, as all good things in India begin with a beautiful prayer to the goddess of education, Saraswati. And I've had the pleasure of hearing Kamla ma'am's prayer a few times before, and she does it very well. So, I requested Vedanthan sir, Dr. Kamla is Vedanta sir's better half, and I would request her to start with her Saraswati Vandana. Ma'am, please.
Thank you very much, Dr. Kunal. Ya kundendu तुषारहारधवला या शुभ्रवस्त्रावृता या वीणा वरदण्ड मण्डितकरा या श्वेत पद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेष जाड्यापः सा मां पातु सरस्वती भगवती निःशेष जाड्यापः.
Thank you so much, ma'am. This was a wonderful rendition of the Saraswati prayer. And
Thank you.
yeah, and thank you for accepting our invitation and doing this for us. It meant a lot to us. Now, I think I can ask Namisha ma'am for a formal introduction for Dr. Vedanthan, and then we can progress to the academic program.
Thank you, Kunal. I'm told that Dr. Vedanthan does not need any introduction to either India or US in the world of allergy. But, well, for formality's sake, we will start off, sir, with Dr. Pudupakkam K. Vedanthan, or Dr. PK, as he is commonly known to the people who work in the world of allergy. He has had an illustrious career, as expected, which started in Mysore Medical College, went on to internship and the post-graduation in the United States of America at Rhode Island, and a fellowship in Colorado, where he worked in allergy and immunology. He is certified by American Boards of Pediatrics, Allergy, Asthma, and Immunology. He is a private consultant as well as a clinical faculty in the US. He is the founder and chairman of International Asthma Services, which are active in various countries globally, especially in India and in Kenya. He is co-director of Asthma Allergy Training Program and is a visiting professor at CMC Vellore. He has conducted training programs in Gangaram Hospital, AIMS Rishikesh, PGI Chandigarh, Bangalore, and Kozhikode. The list of accolades that he has had over the years is too big to enumerate. But as you can see, for a father of allergy, we do not expect anything else. Without wasting any more time, we will hear you, sir. Thank you so much for being there.
Can I share?
Yes, yeah. So you can share your
Okay.
screen.
First of all, thank you very much for inviting me to participate in this very important meeting. Can you hear me?
Yes, sir, we can clearly.
Okay. First of all, this is probably the most appropriate meeting because I am speaking to a huge mature group of immunologists, and allergy is an immunological field, so it makes it very meaningful to talk to your group. And before I start, I would like to thank Kunal, whom I know quite well since he is in our program at PGI. And he was so impressive. At the first session that we met, I told him, why don't you take the immunology class? And he did. So instead of me taking, he took it and I joined him. So a very, very impressive person. And what Kunal is doing with his group is more impressive, bringing the allergy to the forefront of the proper crowd, that is the immunologists. I appreciate the comments and introduction of Dr. Namisha and Dr. Sharma, as well as our Dr. Hisaria at this. So without wasting a whole lot of time, and I would like to thank Kamala for starting off with this inaugural song on Goddess Saraswati, and that actually gives us the right aura today. to talk about additional knowledge or sharing our knowledge. So if it is okay, let me go ahead and share the slides. Let's see. Let us see, where is this? Can you see Kunal and everybody?
It's there, sir. I think you have to start your presentation mode. It's not in the present.
Okay. Presentation. Is
That-
it,
Yes, sir.
it's okay now?
Yes.
Okay, this is the campus of University of Colorado. You can, in the back, you see the Rocky Mountains. It's a very, very pretty state, and it is called Mile High City because it is at mile high. It's 5,200 feet above sea level. And an hour from here, you could be at 10,000 feet up in the mountains, sometimes up to 14,000 feet. So we are all mountaineers that way. So the way we do things is different from people at sea level. So anyway, let us move on. Let me see. Today's talk is a basic talk. It's on basics of allergy and a clinical approach to an allergy patient. Before I go into specifics, I just want to say this particular basic talk, I would like to lay a firm foundation in your minds. So please pay some attention to what is being presented and always make it a point whenever you are seeing a patient, whenever you are discussing anything with anyone with allergy, whether it's a meeting or you're presenting at a conference, always think about basics because you have to apply the basics at every level to not only keep things simple but sensible. So, few general comments I have. That is, we take allergy for granted. A lot of times people do this. One second. Let me move. A few general. Actually, allergy looks simple, but it is not simple. It's actually complex. Okay. Especially with the marriage of allergy with immunology about 60 years ago, it has become more complex, but at the same time, more understandable and more scientific. And so you in spite of all the the advances that we have made in the lab, at, even at the molecular level, the subject of allergy remains clinical. So as clinicians like we are all, the first thing we have been taught in medical college as well as in postgraduate institution, always take a good history. So the history is giving you the diagnosis actually. Patient gives you the diagnosis. If you do a good job, patient is giving you the diagnosis. What you are doing with all the tests is to confirm your initial impressions. That's all you're doing. The laboratory tests do not give you diagnosis. It is the history that helps you to go in the right direction. It's the correlation that makes sense. So, few other things. When we talk about allergy, we sort of make it look simple that a particular dust mite we show in the picture. This is what's causing the problem. This is what causing the problem with cockroach pollens. But what you need to know, it is one of the multiple antigens that are operating at the same time on the same patient. It could be. So these things look simple, but it is more complex than what the slides look. And allergy can change in anyone at any time. Anybody. See, for example, myself, I got sensitized and I'm on immunotherapy with insect venoms. I never had allergies as a child, but I'm 78 and 4, 5, 6 years ago, I probably have a stung, but I got sensitized. I had a mild systemic reaction. But 3 years ago, I am on immunotherapy. So what I am a prime example to show that it can start any time with even not even a history before. So basically, being a clinical diagnosis where you can't see a whole lot, like you see in some of the other dermatological type of conditions, allergy, sometimes the patient looks healthy. So a lot of awareness as well as imagination is essential. Now, we always thought allergy is a new disease. Oh, it wasn't there a whole lot of years ago. But actual reality is it's an extremely old disease, but was not recognized. There is first evidence of a fatal allergic reaction. It is which is anaphylaxis. It was reported in 2600 BC in Pharaoh Menes, a young pharaoh, able-bodied, when he was conducting his cabinet meeting. His ministers noted something stung him. Within a few minutes, he collapsed. He died right there in his chair. And that sounded like a terrible tragedy, which is a tragedy, but no explanation was forthcoming. But the ministers made a very, very interesting type of observation that this sad, tragic episode was caused by something external. Something external caused this problem. So our king had something internal to have this reaction. Something external caused this reaction. So that, but nothing happened for thousands of years until the our forefathers, very, very intelligent scientists. Some of them are not even physicians. Some are come from
नहीं नहीं
pharmacists.
बोलो बोलो
Some
सुन रही हूँ
are non-medical.
हिस्ट्री
They
बता रहा है
made sort of observations that there was about allergy. Clemens von Perquet was the one who coined the term allergy because he thought it is something different type of reaction. And allergy means altered reaction. So he thought it is something different from normal. Okay. And Prosnitz and Kushner, two French scientists, made a remarkable discovery. What one of them, I remember Prosnitz was probably highly allergic to sea anemone, a fish, like a seafood. If he took it, he would have a mild anaphylaxis if it, so he totally avoided that. Dr. Kushner did not have such allergies. He was a perfectly, I don't know whether he was a totally normal person, but he was not having any type of food allergy to seafoods. What the experiment was they took the serum of Prosnitz and injected into Kushner and have Kushner ingest these different seafood, especially the sea anemone. And they noticed that the local reaction, locally where the serum was ejected, started reacting. So which showed there is something that has been transferred from Prosnitz serum into the system of Kushner, and that's causing that local reaction where after he has ingested that seafood. And that is called passive transfer. It was passively transferred. And you can't do these type of experiments now because the lawyers will be waiting to sue you right away. Such experiments we were able to do it 100 years ago, but not now. So that particular substance that Prosnitz had that reacted with the fish antigen, they called it reagin, REAGIN, which actually was discovered after about 50 years by 1968 and 69 by Isizakas and Johannesson as the IgE. So I was fortunate to do a fellowship in the same institute where IgE was discovered. And I have not met the Ishizakas. They were there at that institute a couple of years before my fellowship. I finished in 74, 76. They were there probably around 72, 73. So, but we were working in two rooms beside their lab. So we knew exactly what desk he was working, where it was discovered. So it was a sort of an incredible type of experience and a great feeling to work in a place where the discovery of IgE was made and the marriage of immunology with allergy occurred. Why was it not discovered all these thousands of years? Now, IgE actually is present in everyone. I will come to that in a few minutes. Now, coming back to allergy, it is an exaggerated or an altered reaction. It's an immunological reaction due to IgE antibody, which is very specific against harmless substances, which we call as antigens. And these are benign substances. Nobody looks at dust mite, cockroach, and pollens. We are not even aware of such things. And they are not seen also. They are microscopic. They don't smell or anything. But the immune system, you may not know it is existing. Your eyes, bare eyes, may not see it. But the immune system has its own eyes called immunological eyes. It will detect, especially if you are an allergic person, your immune reaction is already overactive. It will detect these the so-called benign antigens, but react in a significant way. And the actual reaction is more protective, but the protection is so strong it actually causes harmful side effects, and that is what we treat. That is what allergic disease is. It's an inflammatory disease. Now we use certain terms almost interchangeably. We use these words atopy, we use word sensitization, we all definitely use the word allergy. We say this person is coming from an atopic family. But what is atopy? Atopy is nothing much. It's a genetic state. That means that particular person is genetically wired. He does not have any symptoms. He may not have any positive skin test, but is genetically wired. Okay. But such people who are atopic, if you follow them over a period of years, they will get sensitized at 7 to 8 times more risk than an atopic person. What is sensitization? Sensitization is where the immune system has recognized this particular antigen or foreign as foreign and tells I'll show you the reaction, and detects it as a harmful substance and produces the IgE antibody. So the presence of specific IgE antibodies against this particular antigen, it could be dust mite, cockroach, food, whatever, it is called sensitization. So sensitization is an immunological state. Comes next the allergy. Allergy is a term that we are supposed to use only when you are having symptoms due to this antibody reaction. So it's a clinical state. So one is a genetic state, another is an immunological state, and another one, the one that we talk about all the time, is a clinical state. So these are certain sentences that are clear, at the same time a little confusing to few people. You can be atopic but not allergic. That means you may be genetically wired but not have any symptoms, not even sensitized. You can be sensitized but not allergic. That means you may have IgE antibodies floating in your system. Your skin test will be positive. Immunocap will be positive. The CRD could be positive, but you may not have any symptoms at all. We see this. Say like 100 of you, I skin test all of you with dust mite, and 50 of you will show positive reaction, 30 of you will not show any reaction, but 20 of you will have symptoms, but also having positive skin test. So the 20 of you are sensitized and allergic because you are having symptoms. The other 50, you are having skin test positives, but no symptom. That means you are only sensitized. The other 20 are having neither. I don't have skin test, I don't have the symptoms, but if I take more history, my uncle had allergy, my sister had some symptoms of eczema. So you are wired, but not having any type of um, immunological type of changes or clinical changes. There is, if you're allergic, you're always sensitized. That is, we just looked at that. Now, there are few exceptions for it. For example, myself, I was not atopic and I was not sensitized, and suddenly I became sensitized and allergic. So these things where without any such history, you can get sensitized and allergic would be latex allergy, insect allergy, drug allergy. These are three exceptions where such thing allergy can just come on without any type of previous history or sensitization. Now, gene environment interaction is a very, very fashionable word in medicine. Now it has been slowly, it took over, I think, vitamin D. And now the fashionable word is microbiota. Everything is microbiota. For a while, it was definitely everything was gene environment interaction. But we know and we have proof to say allergy is a classic disease of gene environment interaction. What is a genetic defect in allergy? I'll tell you next slide. Just look at this normal epithelial barrier because epithelium is involved in all persons with allergy, atopy, or sensitization. A normal epithelium is a very, very strong organ. See, the biggest organ we have is skin, and then we have the mucous membranes. We are lined with epithelium. Epithelium could be, like stratum corneum, and there are several different layers. Then you have the epithelium of the mucous membrane is lined with epithelium in the gut as a respiratory tract. So if you spread all this different epithelial surface we have in the body, it could be bigger than a small, more than half a tennis court or maybe more. So that means all of us just being in this environment, our body is exposed to the outside environment almost 50 feet around. So we have that much of interaction with the environment. We are always interacting. We are never alone. We are always interacting with the environment. Okay. Now, for you to remain perfectly normal, no symptoms, nothing, you have to have a perfect epithelium, tight epithelium, both in your skin and mucous membrane. And that is obtained by having these tight junctions, adherent junctions, desmosomes. You please look it up in the referrals that I have given you. Beautifully given all the different barriers that we have. Now, what happens in allergy? In allergy, what happens is there are two basic genetic defects in allergy. One is there is a type of gene called susceptibility genes for susceptibility to allergy. And then you have that will have high expression due to by exposure to environment or due to epigenetic changes. So when you have a hostile environment and you're genetically prone, what happens with a genetic defect is your epithelium in atopic person or allergic person is not normal. Any allergic person or atopic person or sensitized person does not have a normal epithelium. Epithelium structure is compromised. What is if you really want to keep it very simple, you have to just imagine the marble floor. In straight line, perfectly aligned. But why is this aligned? So why is it so perfect? Two tiles, you have the grit holding tight, and that is the grit we have in the skin. Between each epithelial cell, there's a grit made out of several different substances which you can read about. And that grit, and not only, and in addition to the grit, these epithelial cells are held together by these adherent junctions, the tight junctions, desmosomes, and they are all anchored to the basement membrane. So it is very, very firmly held. So because of this, it is very tight. So when it is compromised, when the grit is low, when the grit is damaged, the permeability of the epithelium becomes loose, it becomes porous, then the environment molecules which are right outside, pathogens, allergens, pollutants, all enter, and they actually cause uh, inflammation. It causes micro-inflammation, and these people, the second genetic defect they have is when they have inflammation, they have what we call as a skewed Th2 response. They are more prone to have a Th2 response. So because of this combination of epithelial dysfunction and skewed Th2 response, these persons will become sensitized or allergic. So this is a basic defect which can occur in the skin. It can occur in the mucous membrane. That means it can occur in your skin and also in your nose, in your lungs, in your GI tract, in intestinal tract. The same thing happens. So this is a basic defect. So this is a diagrammatic picture of an allergic reaction. Since you're all immunologists, I'm not going to get into too much details, but basically the sensitization occurs with the initial entry of the antigen through a damaged or a compromised epithelium. There is this very intelligent cell called the dendritic cell. We call it antigen presenting cell, which immediately picks up the antigen and engulfs it, prepares it, chops it up, makes it presentable to the T cell, which is and the T cell, naive T cell, once it looks at the antigen, if it doesn't like it because of the genetic predisposition, becomes a Th2 cell, which in turn right away through IL-4, IL-13, it is like food. All the cytokines are like food. It gives that particular food to the neighboring B cell, which is right there, and which actually goes through what we call as class switching. Normally, B cells are producing a lot of IgG and IgA like that. Immediately switches to IgE, and the IgE is produced, and the B cell will release this IgE, and some of it is free. It is called free IgE circulating in your serum. That's what we measure when you do immunocap or specific IgE determination. And these IgE molecules also get stuck onto the mast cell and basophils, which have got the receptors on it. And these receptors are very, very efficient, and they are very sticky. That's why it's called homocytotrophic antibodies. Sticks on. Once it sticks on, the IgE, whose life half-life is only 2.5 days normally, will increase that sticking onto the mast cell. It becomes much more stable and lasts for 3 to 4 weeks. So the IgE, the half-life is increased. There could be 10, it could be 100, 500 IgEs on each of these masses. You never know. So it depends upon the number of receptors. And now once the mast cell, which is got all the specific IgE on the surface, is present in the tissues, that is called armed mast cell, ARMED. It is ready to attack. The next time the antigen enters, ready to attack. So the next time the antigen enters, it doesn't need any antigen presenting cell or anything. The mast cell is right there waiting, the second exposure. Immediately it is taken up by these two IgE molecules. It's called coupling reaction. Coupling reaction means you need two hands to clap. Just like that, you need two specific IgE antibodies direct against the same antigen to catch the antigen, and then the changes happen inside the cell, calcium rises, and all these mediators that are released. Now, a few words about coupling. You need two identical specific IgE antibodies sitting side by side to catch the antigen. I told that. What is the chance of two identical persons in your organization, in your class, with the blue shirt sitting side by side? If there are 20 people, very less chance. If there are 200 people, definitely there's a chance two blue shirts will be sitting side by side. Similarly, if you have more specific IgE are sitting on the mast cell, then chances of two identical IgE antibodies sitting side by side is much higher. So having a positive skin test means you have a lot of IgE sitting there. That's what it means. Okay, the bigger the reaction, more IgE, more histamine production. So histamine and tryptase kinase are what we call as preformed mediators. They are already ready in those granules. So just one clarification for you. Mast cells do not circulate in the blood. They are only the immature mast cells which come out from the progenitor cells circulate. But once they are mature, they go and get settled in tissues, skin, mucous membrane, and all that. And the reason why they are called mast cell, because they are well fed. That is the reason. Mast means well fed. They look fat and they look good. The granules look really rich, and these granules are rich in mediators like histamine, kinase, tryptase. They also have the capacity to produce the late phase reactants like prostaglandins, leukotrienes, which cause the late phase reactions. So this is the allergic reaction orchestra that you have to know. Where does this occur? It doesn't occur in your blood. It occurs in your lymphatics. It occurs in your lymph nodes, where you can see there's a T cell zone and a B cell zone right by side. And it is not unusual for persons with allergic problem to come when you are examining them. They say, my nodes in the throat, in my throat it hurts. So if you look in the throat, you see a lot of lymphoid follicles, prominent lymphoid follicles. The reason why they are prominent is that is where the allergic inflammation, what I just told you, is occurring. And the same thing is occurring in the regional lymph nodes. So the action, the allergic action, allergic orchestra is occurring in your lymphoid tissue, whether it is skin, whether it is lungs, whether it is your GI tract, wherever. That's where it is. So that is why one of the ways we treat immunotherapy is intralymphatic immunotherapy. We give the stuff right into the lymph node. It's highly effective. We'll talk about that later. So I already told you there's an early phase which occurs within a few minutes, and that is due to histamine kinase tryptase. Then there's a late response, starts 6 to 8 hours later. It is a late response which causes an intense inflammation because it calls in all these different inflammatory cells, eosinophils, neutrophils, all these cells will come and causes a huge inflammation. The late phase reaction are at least 30 to 40 times stronger than the early phase and lasts for several hours. And that is why patients come and see you. Because of the late phase reactions, we see these patients because it never stops. So when the late phase reaction is occurring, what is occurring is there's a lot of tissue damage because inflammation. Inflammation means swelling. Inflammation means increased vascularity. Inflammation means it's like a battlefield. So when the tissue damage occurs, what is the first thing that occurs in our body? First thing that occurs when you have a cut in your finger is repair, starts healing right away. You get the blood is coming out of the cut, but at the same second, healing has started. The same thing happens here. Allergic inflammation, wound, it's like a big wound, inflammatory wound. The wound is being formed and it is keeps on going. At the same time, healing occurs. When there is healing, there is fibrosis. At the same time, there is more damage, and that causes the mucous membrane to become irregular, mottled, and that is what remodeling is. That is remodeling. Continuous inflammation, continuous tissue injury, continuous repair occurring side by side, it what causes the remodeling, and that occurs in all the areas where there is allergic inflammation going. And that is exactly the reason why we tell all our students, look in the nose. Most of the doctors look at the nose, don't look in the nose. So nasal exam is essential in allergy evaluation. So once you see the nose, we know nose is the mirror of the lungs. What is occurring in the nose is also occurring in your lungs. So a few words about IgE. IgE was not discovered for a long time because we did not have technology. It is present in micrograms, it is 1,000th of a milligram. But the Ishizakas worked really hard, developed the technology, and found that IgE. IgE is because substance that produces erythema. So, at the same time, Johannesson in Sweden, Uppsala, Sweden, had a patient with B-cell myeloma producing IgE. This patient had tons of IgE. So his serum, it was not very difficult to produce to detect that IgE, and that patient became very rich by selling his serum to many different companies. So few properties of IgE. It's a high molecular weight. It will not cross the placenta, and the fetus immune system is already developed around 8th to 10th week, so it is capable of producing IgE at 8th or 10th week of gestation. So if you take cord blood and if you measure specific IgE against different foods or inhalants, that means the fetus is sensitized. So that means you can be sensitized at birth itself. So this is the allergic march, which people will talk to you later on. It looks like a very ideal type of situation. First the eczema comes, then the food allergy starts, and the asthma starts, allergic rhinitis. But it is too simplistic. In real life situation, there are only a few patients will fit into this. A lot of your patients do not fit into it. But for teaching purpose, it's an excellent model. But in real life situation, it may not be as simplistic as it shows. Now let's look at now with that type of background. So we will go for that. So a typical allergic patient who will present to you is usually an anxious patient. He's also a confused patient. Why is confusion? Why is anxiety? Because he will have seen so many people who have discovered, we would have talked to so many others. So they did a survey in US. How many health providers an allergic patient would have seen before he comes and see a consultant like you? 12 to 13 health providers have been consulted. He has been talking to them. Each one tells a different story and explanation. Somebody will say, hey, you will outgrow as you get older. Or they will say it will get better. Or just take these antihistamines, you will be okay. Or just take this inhaled steroid, take it whenever you want it and you will be fine. He does all that and he feels also somewhat better. At the same time, it keeps on coming back. So he's confused. Oh, I'm not getting a cure. So what happens is he will seek different type of approaches and gets more confused, many questions. When he comes to you, so-called allergy specialist, he expects an answer for every question he has. And he thinks you are going to diagnose every allergy problem that he has. So he comes with very high expectations. So first thing we do is education. Now we will come to that in a minute. So how do you diagnose allergy? What are the three ways of diagnosing allergy? Since it's a Zoom session, I cannot ask those questions and get answers from you, but I have done it in real classes, and there are generally the most three popular answers I get from the audience, which is perfectly rightfully given answers. One, history, another one is allergy skin test, another one is immunocap. This is the most common answer. But actual answer is this. History, first answer, second answer, history, third answer is history. So it is the history only that is giving you more information, more workable type of formula for you to come sort of a diagnosis, what we call as a working diagnosis. We call it working diagnosis is obtained by history. So a detailed history is most important. Sit down with the patient, and most important part of history taking, let the patient talk instead of you keep on talking. Keep your cell phone away. Don't look at the cell phone. Have your assistant handle it. No, with 1 hour, nothing important will happen. If there's something important, you will get a call. Now, when you do a history, do not look at the computer. Look at the patient. Have eye-to-eye contact. Listen to the patient. There was another study that was done in the US. It actually got published in the New England Journal. How many times does a health provider interrupt a patient during history taking? You will be amazed to know 18 times. 18 times we interrupt patients. Another thing, you have to spend time because you have to realize the patient has waited 1 or 2 months for those 15, 20 minutes or even half an hour. But for you, it's another half an hour, that's all, or 15 minutes. For him, it's 3 months of waiting, anxiously, preparing for it. So he comes with all that expectation sincerely in front of you. So if you don't spend sincerely time, eye to eye contact, full concentration on the patient, those 15, 20 minutes, you can imagine the damage done to the psyche of the patient about you. So it's very important. So when you get a comprehensive history, you have got the foundation. Once you have the foundation, as you're taking the history, you form the foundation. Is this patient allergic? Does he sound allergic? Or does he sound not allergic? It is amazing to learn that allergists, when they see patients in their office, if I see 100 patients, only around 40 to 50% are allergic. 50%, sometimes even 60 are not even allergic. They think they have allergy, but they don't have allergy. So it is a portion of the patients who come and say you have true allergy, a huge portions are not having allergy, but they think they have allergies, and what they need is education. So they are falsely positive. So most important part of doing all these tests and correlating with the history. We'll talk about it in a minute. Now let's come to the case. Arjun is a 6-year-old presented with itching, nasal congestion, sneezing, blocked nose for the last 3 years. Symptoms are persistent every day, year round, mostly indoors, aggravation late summer. He has got some seasonal changes. He also has nighttime cough, one episode of actual wheezing, and in between absence of symptoms, the parents think he doesn't have symptoms. But one thing, he avoids PE. Somehow he avoids. He doesn't want to run. He doesn't want to play. He sits around when other children are playing. So there is a reason for that. So because of all these issues, he has got an impaired quality of life. Children with allergies, upper respiratory or lower respiratory or both, have a disturbed sleep pattern. We will talk about that when we talk about chronobiology. 80% of allergic rhinitis patients have more than 10 awakenings at night. 80%. And that means their sleep pattern is not good. When you don't sleep, you're tired. We know that. So these children get up tired, grouchy, moody, and their performance at school is not good. So they're academic failures. Academically, they start failing. At 10 o'clock, he starts feeling sleepy. What about adults? Same thing. A bank manager, we knew, when he fell on his desk sleeping because of his sleep issues. We have many, many cases like that in the sleep labs. So basically, impaired quality of life. Now, history indicated that upper and lower way involvement, but lack of symptoms doesn't, just because he does not complain, doesn't mean everything is normal. That means without patients complaining, you can detect some abnormalities on testing that happens with pulmonary functions. And asthmatic can have a normal lung function. Non-allergic person can, patient without allergy can have a positive skin test. So not everything is normal there. Doesn't mean everything needs to be treated, but you need to know, just because no symptom doesn't mean everything is normal. And lack perception. How much perception people have about asthma and allergies by parents and by patient is pretty poor, especially asthma. They cannot perceive their asthma. Now, when you are done doing the history, you at the same time you have to start thinking. Patient said itching, patient said sneezing and having running nose and all that stuffy. It indicates a mast cell reactivity, histamine release, immediate reaction. So it is considered consistent with inflammation. He has talked about a history of upper airway and lower airway. So both airways are involved. That means the symptoms have progressed from upper airway to lower airway. So this is a progressive in nature. He also has more symptoms at night. That means this is nocturnal problem. The symptoms may look localized, but actually allergic disease is systemic. It is affecting the whole personality. So this type of thinking should occur along with the history taking. This is called thought process. Once this type of thinking occurs, you are proceeding with the environmental history, housing condition, it is damp, ventilation is poor, no pets, no biomass. Grandfather smokes outside. They think smoking outside is a good thing. But actually, in India, it has been shown that who is standing beside grandfather is the child. 95% of the child, there's a child on his lap or watching him standing. Although it is a third hand smoke, it is causing problems. Family history is very important. In this case, mother had asthma. She thinks she is pregnant. She wants to know what is the possible prevention of these issues in the next offspring. So these things are cropping up. So thought process. They said dampness, not a good thing. Even with people with no allergies, dampness is not a good thing for respiratory performance. Positive family is extremely significant, especially maternal history, because it's a genetic disease. It's an autosomal dominant disease, imperfect penetrance. I don't know much about genetics, but I know this is a strongly genetic disease. And third hand tobacco smoke is still significant. So these are all things you should think about. Physical exam, when you do it, there's a pale boggy nasal membrane, tonsillar hypertrophy, cervical node flaps, because of active allergic inflammation in the lymphoid tissue, what we just talked about. And when you looked in the nose, that he has already got a remodeling of the membranes. Clear lung fields he has, but does not mean that he does not have asthma. So these are the things that you should be aware of. So, but in between the you see, history and physical exam, you have to be parallelly thinking about these things. You can't examine a patient, start looking at your phone or a textbook and say, this is the way it looks. You patient will have a very poor impression. Now, a few words about disease progression. These are very subtle things. These are not in the guidelines. This is not in your textbook also. So there are certain things patient tells you very not paying a lot of attention. They just tell these things. It could be in the first visit or it could be in the revisit. They say, where there is a slight increase in the frequency of symptoms. You used to have mostly problems in the daytime. Now he's also having a little problem at night, but this doesn't bother me. Or they say, he used to get better with 1 teaspoon. Now he needs 1.5 teaspoons of the medicine. Or they say, if I miss a medicine, that he has some symptoms. Or the medicine used to work very well, but not that great now. Or she may say, then no, it is sort of the time that takes for the medicines to work has actually is taking longer time to work. These are subtle things. But what it means is the disease process is changing. The disease is progressive. So when you get this type of subtle things in the history, you should start thinking, yes, these are subtle things, but it indicates clinical progression. So if you do skin test on these patients, we do this in pediatric patients. We skin test them for a few antigens every 6 months. We do that. We see immunological progression also. The dust mite and the skin test, which was like 6 by 8, became 10 by 12. Cockroach became bigger. Mold became bigger. Pollen starts coming in. Sensitivity, which means there's immunological progression. That means there's a clinical progression, immunological progression. They go parallel. When that happens, your thinking process should advance towards, oh, this patient is probably a candidate for immunotherapy. I'm treating with all pharmacotherapy. I'm using the right medicines. I'm using inhaled steroids. I'm using antihistamines. I'm using anti-leukotrienes. I'm doing environmental control. But in spite of it, the disease is progressive. That means nothing is totally stopping the T cell firing the B cell. Environmental control can do some, but not inhaled steroids, not antihistamines, not leukotrienes. They will not work on T cells. So the only modality that works on T cell is allergen immunotherapy, which you are going to talk later. So for example, this allergy march was not present in this patient. So this is a summary, as I have told you enough repeatedly. So when you want to evaluate this patient, allergy skin test is definitely useful. It's very simple to do. Spirometry is definitely also useful, maybe normal also sometimes, but history is strong. You don't need impulse oscillometry. It's very useful, but not in this patient. Total serum Ig is definitely not a useful thing, not a good thing for anyone. Total eosinophil count is also not useful. Nasal smear is also not useful. Immunocap is a good test, but not needed because you are already doing the skin test. They do the same, prove the same thing. So if you compare those two, skin test is a lot more natural. You are actually measuring the response in a bound IgE. That is what a natural state is. Natural state, it is the pollens, the dust mite, the cockroach reacts to the bound IgE. They don't react with a circulating IgE. So when you do skin test, it is more natural. CRD is very sensitive, but not needed here. Pheno, yes, may be useful if you really have a machine, you want to check it out. Free run test is something you may not do it, but we used to do it a lot during fellowship. Free run test is the child has a history of some occasional cough and wheezing, but the lung functions are not very useful. Then we make him run around the block along with the nurse monitoring, and we are able to demonstrate a significant drop in fecal flow or FEV1 in about 80 to 90% of these patients, where the lungs are clear on auscultation, lung functions are normal at the baseline, but you are able to precipitate the fall with just simple physical activity. The main activity that brings it on is a jog. A slow jog will bring it on, or climbing stairs up and down. Now, coming back to skin test, it's a great test. Prick test is a very, very good screening test, well tolerated, safe, reliable, sensitive, affordable. It is about 80 to 85% sensitive, affordable, clinically very relevant. Very good clinical correlation of allergy skin test, the prick test with patient symptoms. Now, another thing that is also impressive with allergy skin test, you can show the mom. You see, this is what the positive, that looking at the positive, there's a redness, swelling, and the mom is excited. Oh, yeah, he's reacting to something. And you can tell the mom that's exactly what's happening in his lungs or in his nose. This is like a wound. So that acts as a positive um, item to improve the compliance. By looking at that, mom feels convinced, yes, I should give the medicine daily. I should give it regularly. So the compliance increases by discussing the skin test results, showing them this is what it is, and telling them this is what's occurring inside. That is actually truth, because it is actually occurring inside skin. You are using it as an indirect evidence of a reaction occurring in the respiratory tract or GI tract, because the mast cells are present in the skin. It's easier for us. So if the skin test is negative, for example, with a strong history, people do a direct inhalation test like a bronchial challenge, nasal provocation test, and all that. But in practice, it is a little hard, especially so in India or in the UK, it is used more often. In European countries, used a lot more nasal provocation test. So this is a skin test, which you will have a session later on, hopefully. We always use control, saline control and histamine control. So we know beforehand what is the baseline reactivity of the skin. That is what the saline gives us. And histamine is telling us whether there is any type of cross reactivity. I mean, interference, sorry. Interference, a patient may forget to tell you he took a cough syrup that evening or something previous evening with antihistamines in it, which is quite common. And that antihistamines in the cough syrup might be interfering with the histamine reading. A positive skin test is 3 millimeters wheel above the negative control. A histamine minimum should be 3 millimeters. So it should be if above the control. So if the control is 0, histamine should be 3. If the control is 3, histamine should be at least 6. So 3 millimeters above. Oh, I'm sorry. Histamine should be more than the negative control, right? If the majority of the time positive control means 3 millimeters above the saline control. Saline control, if it is 2, the positive skin test should be 2 plus 3, 5 millimeters. If it is 3, it should be 3 plus 3, 6 millimeters. If the negative control is 0, that means 3 millimeters is positive. But when you interpret skin test, you always have to look at the negative. The histamine you are doing only to detect any type of interference with antihistamines. So when you want to interpret skin test, always look at the skin test and go and compare with the negative control. So this is a skin test sheet showing you the way it is written up and interpreted. So interpretation is very important. And what you're putting in the skin test report is also very important. It gives you detail. We don't use the plus system. Millimeter here, 1 millimeter here is the same as 1 millimeter in UK or USA. In this patient, if you look at the histamine, it's 3, just mildly positive. Generally, it's a lot more than that. And saline is 0. Let's look at where is the saline? Second one, 0. That means the baseline reactivity is none. And the and the histamine is slightly positive, that there is no interference. Look at the dermatophagoids for a 10 by 9 EP. That means it's a huge wheel, 10 millimeters by 9 millimeters with erythema and pseudopod. E is erythema, P is pseudopod. And another pteroneous is 6 by 6, again E, and that is erythema only. And so there are these patient is sensitized to dust mite, farinae, dermatomygoid pteroneous, timothy grass, dog dander, cockroach, peanut with good positive and negative control. That means this is a skin test report signed by the doctor or the technician. This is acceptable anywhere you go. Now, question comes, are they all significant? We will talk about that in a minute. Few things people have questions. Can you skin test a child? Definitely. What is the minimum age? Usually after 1 year. But I have even skin test at 6 months. How many skin tests do you have to do? Generally about 10 is enough. 15 is max. We generally don't go more than that, 15 to 18. Because how did we come up with these 10 antigens? We analyzed about 2000 charts many years ago and found that 80% of the sensitization occurs due to only 10 antigens. If you want to add a few foods, you could. So that will make it around 10 plus 3 plus 5, some controls, 15 to 17, 8. You don't need 30 to 35 tests in a child. In adult, you might. Their exposure is more. Respiratory antigens, pollens are more. The trees are do not cross-react, so you have to do a few more. So 30 to 35 in an adult. Why do you want to do skin test in a child? I want to see whether the child is sensitized, whether there is specific IgE. Now, do you treat the skin test? No. Do you treat the child? Yes. How do I treat the child? Is I need to correlate between the history and the skin test. Find out if those skin tests that they are showing is clinically significant. If it is clinically significant, I would definitely treat. But one of the things we generally do, even for sensitization, we will start talking about environmental control. I may not even start pharmacotherapy. I may not even start immunotherapy for sure, but I will definitely start environmental control based upon sensitization itself, because that will play a role. It is much easier to do something at home rather than spending all the money on other things which we don't need. And if you look at specific IgE, immunocap, or CRD, they are all extremely good tests. They have high sensitivity, specificity, but very expensive. And they are little more false positives, and they also correlate well. But the advantage with the immunocap is it not interfered with medications, whereas skin test can be. But it is unnatural way of looking at sensitization, because you're looking at the free IgE. The bound IgE is the natural phenomena, and that is what you get out of skin test. So generally, I try to do more skin testing, and I do immunocap selectively, not only because it is more sensible to do skin testing, more natural, less expensive, more impressive to the parents, and clinically definitely better correlation and less false positives. And sometimes you can get false negatives with skin test, around 15 to 20%. Okay. And these are the things you need to be aware of. So this is a spirometry test being done, and some children are excellent in it. Some children are very difficult. In children, I think pulse oscillometry is a reasonable thing to do, so that you are able to demonstrate airway resistance and obstruction. Much easier than a spiro. But spiro is still the gold standard when it comes to evaluation of pulmonary functions in the respiratory medicine. It is still the gold standard, but pulse oximetry is definitely climbing the steps. Unless it becomes more affordable, it won't become very popular. It's very expensive. In the UK, in USA, it is still considered as more of a research type of procedure, the pulse oscillometry. A children's hospital uses it more, but in general, if you take it a pulmonologist and all that, it is used more as a research. So a lot of allergist offices do not have pulse oscillometry in the USA. They only stop with spirometry. Maximum they have is FeNO. If they want oscillometry, they send them to a center. It's also because of the type of medical reimbursement. Insurance companies will ask you questions. What is the justification you did CRD? What is the justification you did pulse oscillometry? If you do not convince them, they will not pay. Now, when you want to treat the patient, the most important thing allergist can do is not writing prescriptions. First thing he should do is education. Patient is first educate. Talk to the patient, tell them what is the facts, what are the misconceptions they might have, clear that, write down what you just mentioned, and also discuss environmental control. Very, very important. for especially indoor antigens, dust mite, cockroach, molds, because indoor antigens are the ones that cause asthma. Outdoor antigens do not cause asthma except for seasonal flare-ups, but majority of the major asthma occurs due to allergies are all due to indoor antigens. Pharmacotherapy will be discussed in detail later. They probably have discussed already, I'm not sure, but it will be discussed in detail. Yes, pharmacotherapy, we have the best drugs now, best drugs to control these allergic conditions, but you always have to know these drugs will give excellent relief but will not stop the remodeling completely. It may slow down a little, but it will never stop the T cell. It is allergen immunotherapy which will help the T cell function to be dampened, to create a Th1 environment in the present by treatment from a Th2 to Th1. The allergy immunotherapy is the only modality that will help. So in the long term, it is the immunotherapy that will help a allergic patient. So these are the environmental antigens. So indoor antigens are more asthmogenic. So when you want to do immunotherapy, which will be a separate topic later, it is a selection of the patient, selection of the antigen, selection of whether it's a good quality antigen, limiting the number of all these things. The success depends on it. So now coming back to the last question that mom had, how can I prevent allergy in my next child, is a few things. Environmental control should start even during pregnancy itself and should continue postpartum. For dust mite and cockroach, these are the two antigens that cause terrible problems. They go through. Mom has allergies, it will go through and go into the fetus also. Avoid environmental tobacco smoke, including third hand. Have a dog indoors. Very, very, very intriguing type of recommendation. The dog is an incredible source of microbes. It is as much as cow dung. And when you have a dog which you can tolerate, the family can tolerate indoors in close contact with a pregnant lady and with a child that is growing up to, especially below the age of 2, it has got a dampening effect on the immune system going the Th2 pathway. That is called hygiene hypothesis. I don't think it's a hypothesis anymore. Avoid highly polluted areas, especially in the first trimester, first year of postnasal life, because pollution can definitely go through the skin respiratory tract, reach the fetus. So it can definitely cause allergic asthma, allergies. Avoid psychological stress. What does psychological stress have to do? It has been shown conclusively psychological stress is also an inflammatory disease, produces IL-6, causes inflammation, has been shown the prevalence of asthma is higher in these patients who have gone through psychological stress during last trimester of during trimester of pregnancy as well as in the first postpartum life. Promote exclusive breastfeeding. Introduce allergenic foods early. Good skincare, very, very important. Always look at the label. Use the one that has got ceramide, which is a natural ingredient, because many of them have phthalates. So when you want to put anything on the skin, now you know that skin is incredibly immunogenic and it's a porous skin in these patients. You should be doubly careful what you put on the skin. Many times the grandmas used to do that different oils, coconut oil, that oil and all that, which is probably safer than many of these expensive creams that you buy. CeraVe is a good one. Eucerin is a good one. A multi-pronged approach is effective. That means you should do a couple of things at the same time, not just one thing. You should do environmental control, having a dog, having this skincare, all those things should be done. Breastfeeding. If you do 3, 4 at the same time, it definitely has been shown to be effective. So, summary slide, allergies correlate with skin test regarding allergies, correlation with skin test is important. Comprehensive history, anti-allergic medicines are effective but do not modify the disease. Immunotherapy, avoidance measures should be multi-pronged. So I'm coming to the last slide. Allergies are rare? No. Total IgE is the best test? No. It is a specific IgE is a good test. It is a progressive disease. Yes. Allergy skin test is a sensitive test. Yes. Allergy immunotherapy is highly effective. Yes. Children outgrow allergy. No. Total allergy is totally curable. No. This question is very important. Always now patients ask, can you cure me? Can you cure my child? Can you give me warranty like a Maruti car warranty? No, nobody will give warranty in any of these conditions. You can say I manage, with these patients so the child can lead a normal life. So our best wishes to you all. I will stop here. I'm sorry if I have taken more time, and I thanks once again for your organizations for giving me the opportunity to share this information. Any questions will be
Yeah.
fine.
Thank you so much, sir. It was quite a lucid presentation. And I think we have a few set of questions already there.
Okay. Should I go to the chat box?
No, I think Dr. Dhiren will ask
Oh,
the.
okay.
Thank you, sir, for a wonderful talk. It will be very helpful in our daily practice. So,
Thank you.
question was asked by Dr. Bhumik Vignani. I think he was asking about a skin prick test. When you prefer immunocap over skin prick test, or it's expensive, that's why we are avoiding, or any other disadvantage for immunocap over skin prick test?
Skin test is more, other than the expense part of it, one, it is immediately available. Within 50 minutes, patient knows right in front of you what is the sensitization. Patient has some answer. So immediately. So you can go ahead after you have taken the history fresh, and we go ahead and do after the skin test what we call as a summary conference. We discuss the results of the skin test and try to correlate with the patient history right away at the same appointment. Tell them what is significant, what could be significant. So I will have some sort of a working diagnosis, some sort of a management plan in the first visit. It's in that visit where I do the skin test, which could be the first visit itself. And I will not start immunotherapy at the first visit. I will never do that. I will always give time. I give like skin testing doesn't mean you have to start immunotherapy. Skin testing means knowing the sensitization. Skin testing means trying to correlate to find out what is relevant. So these decisions are made in the first visit. So you can start educating the patient and start environmental control, start pharmacotherapy. Second visit or even visits around 6 months. Take even 4 to 6 months before you decide immunotherapy. Don't be in a hurry to start immunotherapy. Always see the progression. If it's a progressive disease, it's a clinically progressive disease, and immunologically progressive disease, you repeat skin test. And many times, the decision to start immunotherapy comes from the patient. Patient says, mother says, can you please start immunotherapy because other son did well. So sometimes the pressure comes from that. So there are many advantages of doing skin testing. For a mom, immunocap is definitely less impressive. It is a piece of paper with numbers he cannot understand. And for us, we can interpret. But again, I told you, it is an unnatural way. You are measuring free IgE. You are presuming that it is as good, which is true, but it gives you false positives. More false positives than skin test.
Great, sir. So just to continue, there one more interesting questions. The component of skin prick test that depends on the region you live, or it's based on history, which we ask. Like what we will testing it, like cockroach or any other. So component it depends on what? It's fixed component, or it depends on history. How you select?
Can you repeat it? I couldn't understand. Just
Oh,
slowly tell me what is
yeah.
the.
Sir, the
Yes, yes.
question, the question was.
Let me shut off my video. I will hear better. 1 second. Yeah, go ahead.
So the question was, sir, how do you decide what to test in the SPD? Is it dependent on where you live, or does it depend based on the history you have gotten?
Very, very important question, doctor. Now, the number of skin tests, the type of antigens that you test with depends upon patient's history. Somebody will say, I took this particular fruit and I started itching. You don't want to test him for all sorts of dust mite and mold. You test for those particular thing and some cross reactivity. So it depends on the history. So depending on the history, you will go ahead and do skin testing. And if it is a respiratory allergy, we know there are certain common inhalants that are there. So the most common ones that are asthmogenic, especially if it's a pediatric patient, I will always test for 3 antigens. One is dust mite, another is cockroach, another is alternaria, because these 3 antigens cause asthma. So the pollens changes from area to area. Depending upon the area, your tree pollens could be different. Grasses and weeds are the same. So if you want to select, there is enough material that we have that tells you which are the common pollens in your area. For Gujarat, Ahmedabad, we can tell you what they are prevalent. So depending upon the area, there are certain trees that are more prevalent. Himalayan trees in the South India, what the type of trees. So a aerobiologist will definitely be able to help the selection, but all these selections have already been done for you. So the skin test depends upon history and where you live for sure, but it won't be terribly different from, say, from Karnataka to Gujarat, except for trees.
Probably what also is important is that if there are predominantly indoor symptoms, you will test for more indoor allergens, and if it is predominantly seasonal, you would be testing more pollens and outdoor allergens as compared to the indoor ones. Would it be so?
Okay, if they have symptoms and you suspect mostly outdoor, please go ahead and do test for indoor also. Because if they are getting sensitized, you can start environmental control, because we know those three indoor antigens are more damaging than the pollens. They are the ones that cause asthma, and there are excellent studies to show that by doing environmental control, by reduction of the exposure, you can actually modify the disease, because it actually works on the T cell. By environmental control actually is one of the ways working, because it are reducing the antigen exposure. The antigen presenting cell is speaking less of these antigens because it's not there, or they are minimal. So it is actually, if you do it properly, environmental control has a definite role, and it is, anybody can do it. It doesn't cost anything major. We even encourage pediatricians who are not allergists to go and do few skin tests and start environmental control, because environmental control, the earlier you start, more benefit you get.
Yeah. So there's one more question regarding atopy in pregnancy. How do you manage? Is it heritable?
Which one? Which one? In
Pregnancy,
pregnancy and,
how do you manage it, and is it heritable, the allergy?
you mean atopy and pregnancy, did you say?
Yes.
Atopy means you are genetically prone. Okay. Whether that person is sensitized, whether that person is clinically significant, I have no idea. You, by talking to the patient, you get an idea. But do not do skin testing on a pregnant lady. Do not do skin testing. This is one time, if you really want, she wants to know you're sensitive, this is when you do immunocap. You do specific IgE, just do a few. Those three should be included: dust mite, cockroach, and the mold should be included, because these are the ones that can cause problems. So just do about 5 or 6 antigens and tell the mom, do environmental control during that time. If there is a very strong, say like the mother says, I had childhood asthma and she's pregnant, she's totally asymptomatic, the chances are this patient is already sensitized. Go ahead and do environmental control in those patients. And
Okay.
evaluate their asthma by doing lung functions, because you don't want uncontrolled asthma during pregnancy. But do not do skin testing.
Okay. Probably the question, or if I can modify the question, the delegate wants to ask that is management of allergic disorders in pregnancy any different? And can the allergist do or advise anything to prevent the child having the same set or same degree of allergies as the mother has had?
During pregnancy, it depends upon what you are treating. If the mom is having symptoms, you actually are more aggressive. Okay, it is okay for you to use inhaled steroids. Okay to use certain types of antihistamines. You look at the class, be a whatever. Okay, get involved. The obstetricians should have an allergist or a pulmonologist get involved in his care. Okay, it is always a good idea to have as normal a function, lung function as possible during pregnancy. So pregnancy, if you have allergy, you should treat it. Okay, do not withhold medications, because the advantages of having a normal physiology compared to an abnormal physiology by withholding is, the risk is more to the fetus. So the fetus will benefit having a well controlled asthma allergy situation. Okay. As far as the diet, mom will say, can I eat, should I go ahead and stop drinking milk and peanut, this? The evidence has shown there is no reason to restrict diet in a pregnant lady. It does not seem to be a factor. So she can go ahead and eat normal food. So it has not been, you do not have to restrict the mom's dietary pattern during pregnancy. And I already have mentioned about tobacco smoke. She should avoid high traffic zones. I've already mentioned that. And having a dog, having that microbial exposure is a helpful thing. I already put it in the last slide. So please look up that.
Okay. There's, I think, one question that you did answer during your talk is what is the earliest stage of doing an allergen skin prick test in a newborn? So it is ideally recommended above the age of 1. But if you are experienced and confident, probably you can do it at an earlier age also. I don't think.
Actually, it is very easy to do skin testing in a 6-month-old. He doesn't know what's happening. Okay. The only thing, it is a technique that matters. The skin of an infant is very thin, so chances of causing some bleed is there. Even there's a little bit bleed is okay. And also there's a possibility whether there is a maturation of the skin by the deposition of the mast cell. Is it mature enough to come and get lodged in the skin tissue is another question. So generally people wait 6 months to 1 year, but say like it's a child. It goes by individual. There's nothing like a blanket thing. I had a child who was given cow's milk at 6 months and broke out with hives. What do you do? You can do immunocap, you can do skin test also, you can do both. I did both, and I found a 6 by 12 millimeter reaction to the milk antigen. Okay, and a significant also higher values on the immunocap. So it depends on the individual situation. You can do skin testing if there is parental anxiety is not that great. And another thing you could do is use a local anesthetic cream called EMLA cream, EMLA cream. When you do about half an hour before, it will anesthetize the skin. It will not interfere with skin testing. And in children, no need to do more than 5 or 6 skin tests. There is no need to test all sorts. It depends. As they get older, you may have to you do more. But in less than 1 year, 5 or skin test is more than enough. You can easily do it on the back. We usually do skin testing on the back, not on the arms. On the back. Have the child lie down on the abdomen and then do it. Because also the mast cell concentration varies from area to area. Mast cell concentration is highest in the upper and lower back, minimal at wrist, moderate in the arms. So a lot of people test on the arms in India because of privacy reasons. There is always some people around there. That's why you can't do bare the back. But in the US and all that, we do it in the back only. We don't test on the arms because the mast cell concentration is maximum in the back, not on the arms.
Okay. Thank you so much, sir. There's a question regarding hygiene hypothesis, and I think one of the speakers did mention about it. But how hygienic is actually so? Can what practices can make our child less prone to allergies? What is the extent to which we maintain our hygiene? Is all hygiene bad?
Let me give you a background of the test we did. If you have time, give me 2 minutes, I'll tell you.
Yeah, yeah.
So we did the first study in India. Myself, Mahesh, and National Jewish Hospital, we combined together. We looked at rural children and urban children. The urban children came from Mysore, and rural children were about 40 miles away. We looked about 130 children. It's a published data I can give you. And we did the ISAC questionnaire. Then we did skin test on all of these people. And we also went to the house, to their huts. I was the one who was going to the hut, collected the dust, measured the endotoxin measurement. That gives us an indirect measure of microbial exposure. Did the same thing in the city. and the results were amazing. And in the village, that they use cow dung to keep the flies away, and there is a lot of animals there, and there's some many huts have even a bedroom for their cattle inside, and there is a lot of dirt. We call it so much so called dirty like that. But what we found was very interesting. One, the microbial load in the rural homes was 7 times more compared to the urban area. The prevalence of wheezing and prevalence of skin sensitization was 6 times less in the rural area compared to the urban area. And when we did all the statistical correlation, the V's is inversely proportional to the use of cow dung. So which means that microbial exposure due to cow dung usage actually protects you from these mechanisms. This has been shown in many places in the West where they found low allergy, low asthma in the farm living families. And they have done studies in the cities where the children, the people who are living in the high-rise apartments are at the highest risk compared to people living in a residential home with a ground where they are able to do some gardening, and the children are exposed to soil and all that. So soil contact is a very essential part of making your immune system go towards Th1 pathway. So there is a book. It is a 500-page book, 250 pages is reference only, and the book's name is Dirt is Good. It's an excellent book. So dirt, we may call it dirty, but it is okay for your child to play in the dirt when they are young, and you don't have to keep everything too terribly clean so that your immune system will mature. And that's what happened to us. We never had any type of because we were always in the mud, playing with mud and this and that and dirty. But now, the type of houses, the type of living, these children have it too clean. Especially with this COVID, you're using this hand sanitizers, which makes it much worse. So you're at a higher risk of developing allergy now than any other time. Too clean is not good for your immune system.
Thank you so much, sir. And I think we're about 15 minutes ahead of our time. So thank you everyone for joining in, and thank you so much, sir. We have two more sessions with Vedanthan, sir. So any questions that you might have right now or after listening to the sessions or listening to his notes, you might again ask him in the next two sessions that he has. I think he has both these sessions in December with us. Thank you so much, sir. If we can see your...
Thank you. I'm sorry if I exceeded the time, Kunal. I
No
don't know.
worries. We truly enjoyed every minute that you spoke, so no worries.
Thank you
Thank
so
you very
much, and
much.
you have a good evening. Bye-bye. Good night.
Thank you.
Bye-bye.
Thank you.